So today we have Liladhar, Babita, and Bhagawati, who are all part of our Nepal team in Kathmandu. I'm actually going to have them go around and introduce themselves and their position and what they do in their position over in Kathmandu. So Babita, let's start with you.
Well, so good morning, good afternoon, good evening to everyone, wherever we are like joining us from. So this is Babita Bindu. I work as a program manager in OHW Worldwide Nepal office. So I have been with this organization for the last 6.5 years now. So it's been great to be involved or engaged with this organization. So I'm so glad to talk to all of you also. So yeah, we'll moving forward, we'll talk more on what the organization does or what I do. Yeah.
Hi, this is Bhagawati Shrestha. I'm here in One Hat Worldwide as a training manager since 2015. My working destination is the Kathmandu now. So you can ask the training program related things later on. Thank you.
Okay, namaskar. I am Liladhar Dhakal, working as a director for monitoring, evaluation, research, and learning. And I'm working with ONAT since 2017, I think. Yeah, it's more than 5 years now. And I will talk more about, if you are interested to know about the monitoring and evaluation and other study that ONAT is doing in Nepal. Thank you.
Perfect. Thank you for those introductions. And so the theme of this call today is to talk about One Heart's impact and how we measure our impact in the field in Nepal and what that looks like for the three of them and how it looks differently. So Liladhar typically works most with all of this data. And so I have put together just a few intro questions. And if you guys have questions at all throughout this, please just go ahead and either say in the chat your question and I can ask it to them, or you can raise your hand or get my attention somehow. So the first thing that I wanted to ask Leela is, we talk a lot about how we're a data-driven organization. Can you tell us what exactly this means for you and for One Heart in practice? And how does the data we collect affect your job?
Thank you. For me, exactly, the data-driven means we use the information or the recently available evidence, what is available in the maternal and neonatal health sector, to decide our activities, our goals, and even the project areas. And further, we use our data, our monitoring data, to decide our everyday program decisions. That's why we called us, we want to take us as a data-driven things, because while selecting all the interventions, we evaluate their effectiveness, whether that intervention or the activities has the evidence of impacting maternal and neonatal health or not. And in selecting the project area, for example, last year we use valuable Nepal demographical survey data, human development report, data, and other survey data, including routine information system. In Nepal, routine health information system is quite strong, and we have the data at the facility level. And we use all those informations, we triangulate them, and we also use our project reports to select the project areas and our intervention. That's why that is what we mean by the data-driven. Because, for example, sometimes even for deciding the dose of intervention, what types of activities that we need to implement in which area of the district. We even do the prioritization of the municipalities. Now Nepal has the municipalities and province and the federal government, and even for the municipalities, because we can't cover all the municipalities with the same dose of the intervention. That is also not necessary even. That's why we prioritize the municipalities and decide our activities. And Palika prioritization also depends on the evidence that we have. Means, for example, data of the health management information system or other survey. And before starting the program, we do the baseline. And the major objective of the baseline is not only set the milestones or the value that we will compare with our inline, but even for the decision making of or choosing the municipalities where we need to focus first. Yeah, that's our practice.
Can you tell us a little bit about the specific things that you would be monitoring? So, for example, when we, tell the outside world what we're doing, we say we've reached this many pregnancies or we've trained this many skilled birth attendants. So, can you tell us a little bit about what exactly it is that gets monitored?
Yeah, monitoring, we have many more activities, and we set up our monitoring and evaluation system for almost all activities. And even in the 1 act, the team is also last. We were about 7 members, and we have the province offices, and we have the Kathmandu office. There are dedicated MNE people. And by nature, our staffs implement activities in the districts, and they collect the information about the input. Means they collected information about the how many training they do in the community, how many people involved in that activities. That's why we calculate people reach. For example, FCSB trained, community health mobilization activities done, how many pregnant women were there, how many recently delivered women participate, how many family members of the pregnant woman or the recently delivered woman participate. Our staff report that type of things on the monthly basis. Actually, we use the tablet to collect the data, and we use very less paper in our MNE system. And we have our MNE plan where we specified what are the input level indicators, what are the process we monitor, what are the outputs and outcome, the impact level. For example, at the input level, we measure how many funds we release and how many staffs are there working. And for the process level, we count the people reached, we count the activities, the number of events that we did. And for the outcome level, our indicators are, for example, institutional delivery. That is the major thing that we monitor. And about the evaluation thing, for the impact level indicators, I already said that we do the baseline and inline. It takes about the completion of the after about 1 or 2 years after the completion of our project activities. And our major impact level indicators are the institutional delivery or the skilled birth attendant delivery and maternal and neonatal death. Sometimes the hierarchy, though this skilled institutional delivery and maternal death, we can also make 2 hierarchy to them, but for our purpose, we are using them in a single hierarchy. Yeah, we measure at least up to the counting of the events and people list every month in our monitoring system.
Perfect. Thank you. And so, Bhagawati, I wanted to ask you, so knowing this about how we collect our data, Leela mentioned about institutional deliveries, and I know that one of our metrics is if births were attended by a skilled birth attendant. How do you see that affect your protocols, your clinical teams? How does it affect your job and what you do? This data and how we, how to make this impact greater.
Sorry, you asked first how you collect and how you impact, right?
Yeah.
So basically, directly the number of institutional delivery, number of antenatal checkup mother, all this system are is a government one system. We don't collect from ourselves. Of course, we train the government staff who works in the government health facility. They have their own data collection system. We call this integrated health information management system. From the health facility, is health worker entry the data electronic and paper-based as well. And this data compiled in the municipality level. And that's how the data collected. And of course, we see the data, the government's data. We didn't have a separate data, the one thing. And the other thing is like, impact is oneself. Of course, data also always drive us, what's things going on right or not. And the other things is like, we raise in every health facility, most of the birthing center of our program district. And we do the need assessment of the different aspect of the health facility, like what is the status of the equipment, what is the status of the infrastructure, what is the status of the trained human resources, and the regular supplies, life-saving drugs, and so on, whichever need for the to run the basic health services. So based on that need, we support to fulfill the gap. So basically, the data is data always come in the mainstreaming at the one system, and other things we also see our results and other things based on our on-site need assessment and intervention as well. And sometimes we also collect the history field from the field level, quote from our different stakeholder. That is all.
Perfect, thank you. So yeah, this actually brings me to something that is even hard for me to understand sometimes when we're talking about, like, for example, in our annual reports, we talk about measuring our impact versus measuring our achievements. And so they're very similar because achievements and impact can be seen as almost synonyms sometimes, but for us, we look at them differently. I've talked with Sabeel about this quite a lot. And so for us, when we've talked about impact, we're talking more about cost sharing, government buy-in, that sort of thing where it's systems change, I believe. And our achievements are sort of how many skilled birth attendants have we trained, or how many community outreach providers have we trained. So can you tell me a little bit, Bhagawati, about how you see the difference in your position between impact and achievement?
It's a little bit tricky question, you know. Normally, achievement we can measure in different level. But from the program implementer point of view, first immediate after output is for the achievement for us after completion of the each line item activities, and the longer achievement we see the impact also. So in our context, for us, number of reaching to the number of people we are reaching for the different kind of activities, like reaching like from the how many number of FCG we raised or trained, how many number of women got the information about the maternal and newborn health related messages, and how many local stakeholders were trained, and they involved in involved in the management of their One Health facility, and how many municipalities and health facility management committee member were ready to do a cost sharing, and then how many they did in actual. All these are the achievement for us in our project. And then of course the impact is the long-term effect from the support and from our intervention. So of course the impact will be, we see the in number, and the other thing is the quality wise as well. Normally we see the impact level in number is a national level data, and the quality also we do have a measurement tool we call minimum services standard of government of Nepal scale of in all at all health facility level, and we are supporting to the government to run the same tool for the review, follow-up, review and follow-up. From that tool we see the quality or readiness of the health facility. I think I get you, Katie.
Yes, no, that was perfect. Yeah. In our annual report from last year, I just looked at it because I wanted to see what else we put in our program impact. So we put in our impact last year about our program cost sharing, government buy-in, access to care, and then quality of care. And so I think that's important because that was hard for me to kind of separate the two. But with all of the data that Liladhar is monitoring and collecting and evaluating, those numbers of how many people are trained, how many, whether that's skilled birth attendants, community outreach providers, birthing center upgrades, all of those contribute to these bigger ideas that you were talking about, I think, Bhagawati, about more national level. So access to care. Access to care means a lot of things. It means trained SBAs. It means that they're able to reach a birthing center close to them, stuff like that. And so I'm gonna turn it over to Babita really quickly, because I would like to ask you something similar about impact versus the achievement. With your position, how do you see that in your position specifically, and how do you use that to either adapt our programs, or do you use those numbers to kind of influence anything or change anything about your job?
So before talking about what you have mentioned or asked here, so as being a program person looking after the operation, so I would like to talk about like what and how One Heart works. You know, like we all know One Heart adopts the network of safety approach to ensure that every woman are being able to access the appropriate ANC, that means antenatal or the postnatal or the essential newborn care, and also get the delivery services from the SBA, and that is the stillbirth attendant in a very well-equipped facility. You know, that's what we work for. And regarding, you were previously talking about the achievements and the impact. So when we talk about the achievements, that means we have lots of activities under different headings, you know, like we give the inputs on different headings. For example, we work for raising the awareness of the women, the community people. Also, we work for, you know, so that they have or they increase their demands to, you know, like get those services and utilize those. And also we work for enhancing the capacity of the service providers. We also renovate or construct the birthing centers. We provide support with the equipment in the birthing centers, and also support the local government in their planning and budgeting process also. So we have a bunch of activities that's kind of inputs for us. So right from the government to the health facility, to the community outreach providers, to the families, to the women itself. So we have lots of activities as inputs. And what we expect as an output out of those is like there's increased level of awareness among the women at the community level or the community people, or also increased demand for the M&S services or utilize those services from the health facility. And also we have the enhanced capacity of the service providers. We have the birthing centers that are fully equipped with the equipment and also with the human resources, and we have the renovated birthing centers. Also, we expect the local government prioritizing MNH, that is maternal and newborn health. That's the area we work on, so that they prioritize this area with enough resources, that in terms of the budgets or the human resources, and the related activities, so that there's a local ownership increment level also. So these are the outputs we expect out of the input that we give or support to the government. And for the larger impact, it's like we all know that we basically look for the deaths, I mean maternal deaths. So if there's a decreased number of maternal deaths, then we think that we have like our project or interventions have a good impact. But it's a very long thing to get all of those, because lots of factors that are the internal or the external factors. There are lots of factors that play a role in all of this, and it's a very rare event also. So the numbers can be sometimes high, sometimes low, but long-term impact is what we or our intervention look after is the maternal death. So that's what we look for, as in, we give the inputs, we expect the outputs that I mentioned, and then the impact is definitely the low number of or no maternal deaths. That's how we look for, as in the program side, KG.
Perfect. Yeah, no, that was a perfect explanation. Thank you for that. I wanted to ask, because you mentioned this as you were talking, that there are sometimes external factors that affect our program achievement or impact. Can you talk a little bit about what some of those external factors could be?
So, we work, we support the government. We work for strengthening the system, the government system. We don't have our own parallel system here. So there are lots of things, like, because the foremost thing now is like local government is very much resourceful. They have the power to have the budgets, and then like recruit the human resources, and also make the rules, regulations, or policies by themselves also. But the health unit, especially that look after the health, so that's not that much capable still to have get a great plan based on the need of that area and all that. So that's still needed to improve there. So that's one part. And some of the local governments have done great. There are some of the health units that are doing really great, but still the improvement space is always there. That's one part. And because also the geography, what Nepal is like, we have the hills, we have the mountains, we have the tarais, they have their own cultural values, systems, whatever, like, so there are some cultures in the society, the community, and that's not letting them to go to the facility or have that access that services also. So those are another thing. And also the geography, of course, like even though people they want to reach to the facility for the services, because there's no road network, so they are not being able to reach there also. And the staff retention thing is also the big problem. So people tend to be in one station for, like, they get trained with the support from the government and also the non-government organization like us. But once they get the training, sometimes they just get transferred, or they leave the job, or they go for further study and all that stuff also. So these are some of the factors or things that has impact on all of the services. Yeah.
Perfect. Thank you. Bhagawati, I want to ask you the same thing. Do you see any external factors that either affect us poorly in the training and all of that, or things that maybe help us? Are there any external factors?
Sorry, most of the things already covered by the Babita ma'am. And of course, the emergencies like COVID,
Right.
which we got COVID and earthquake, which is not under our control. And the other things is like Babita ma'am already shared that we strengthen the government system. So our main primary, of course, the primary, our program intervention wise, first primary stakeholder are the health workers. Of course, normally sometimes for the long-term training like skill path attendant training, rural ultrasound training, we need to send them to the provincial level higher training center for a 2 month, for a 21 days. But in our remote health system, in one health facility, only 1 or 2 nursing staff over there. But when they 1 or 2 staff over there, when they go for the training for 1 or 2 months, there might be service, might be the staff. Because sometimes like especially in the hilly and mountain region, only 1 staff or and they run all over the services. That is the challenge. And the other thing is like of course we are following the government protocols and guidelines. We are sending them to the provincial level higher the referral hospital for their more exposure, to make their to make them more competent in the skill. However, where of course during that training period they will be more confident and more knowledgeful, but after returning back to their one station, the similar kind of cases might not be there, and having a less practicals practice in real case, then their knowledge and skill also automatically go down. So as a training point of view, we need to think always one-time intervention is not enough. We need to do the on-site coaching, mentoring, or training follow-up is a part of continuation of the program. That's how we need to think.
Perfect.
And similarly, we are doing the same thing. Like we don't leave the health workers after one long-term training. After long-term providing a long-term training, we do the on-site coaching, mentoring for the nursing staff. We do the follow-up, so many follow-ups training for the health facility management committee members and health workers and female health volunteers. And we have so many community focused activities to increase the demand, community demand generation, where we are implementing like using the different tool for more participation of the community, and to build the accountability and responsibility at the health facility management and the other stakeholder as well.
Thank you. Yeah, as you were talking, I thought of something else. I know that we were working in the district of Dotting before, and now we are back in it this year. I'll open this to any one of you who wants to answer. I don't know who is the appropriate person, but can you talk a little bit about why we have re-entered Dotting, and is that informed by some of the data that we have collected?
It's not Dotting, I think it is Dolpa.
Dolpa, there we go. Sorry, thank you.
So I think Liladhar sir can answer it more. The inline survey result gave us some idea to re-enter that, right, Liladhar sir?
Yeah, we did inline survey in Baglung and Dolpa in 2019. Both districts completed before 2015. And in the inline, we collected information about the practice, of the utilization of MNH services and how is the readiness of the health facilities. And though there was improvement comparing our baseline data, but comparing the status of the Dolpa in 2019 with the national status and other districts of 2019 and what we wanted in our program districts, Dolpa is far behind. That's why we decided to go again in Dolpa and do some interventions. And another reason is that when we completed our program in Dolpa, many more standards and protocols were old at that time, and because of the change in technology and the medical science, many more protocols and the procedures are changed. That's why there is a need to train the health workers on new protocols, new techniques, and we decided to go to Dolpa again.
Perfect. Thank you. Yeah. And Julie has told me this, and you can correct me if I'm wrong, but one of the things that they have also changed is in the protocols is that instead of just 4 antenatal care visits, they've changed it to 8. Is that correct?
Right.
Mm-hmm. And why have they changed it to 8 instead of 4?
Actually, Nepal prepare all the data and all the guidelines and protocol based on the WHO guideline. WHO suggested that if we really want to decrease the maternal and neonatal mortality rate, then we need to monitor our mother and their fetus continuously. So it was recommended a few years back by WHO, but because of considering with the different geographical challenges, awareness, and our health system is structure, Nepal government was implementing only the focused 4 antenatal care visited. But in 2016 NDHS data, according to that data, what we realized is our maternal mortality rate is not, we are not being able to achieve our target according to our plan. So if we really want to achieve our SDG on time, then we need to do something else. So Nepal government decided to change our strategy. Based on that, the protocol also changed.
And have you seen, I mean, I know this has changed somewhat recently, but have you seen a difference? How are women attending more antenatal care visits because of this change?
Recently, we just been few months ago, we started this program in Nepal. Of course, most of the health workers already trained on it on revised protocols, but it will take time. I cannot say exact, but most of the, like, of course, the information national-wide is already disseminated. Women are starting to come according to protocol, because the government also has a incentivization for to promote the antenatal clinic visits. So it is growing rapidly now.
And can you tell us, how do they incentivize them? Is it, I know that they sometimes provide them food or things like that. Can you tell us a little bit about those, especially people who are not in Nepal?
Yeah, of course, the one of the in Nepal, since during the 2006-8 or since 1996, our major bottlenecks was the 3 DLS for the responsible for the maternal mortality rate. So and that time, so home delivery over there. So the Nepal government decided to incentivize the program including with the scaling up the birthing services in each health facility. So now there are like the pregnant mother who do their antenatal checkup visit as per protocol. They will get 800 rupees as an incentive, motivational incentive. And those mother who deliver at the birthing center, who they get like in Himalayan region 3,000, in hilly region 2,000, and in Tarai region 1,000 is a transportation incentive. And the other thing is the mothers who deliver their baby at health facility, they will get a 2 pair of cloth for their newborn baby, and one pair of cloth for the mothers. This is the standard national-wide incentive to the mothers and newborn for promoting the institutional delivery, antenatal checkup, and so on. And the other thing is, like, after having a federal structure, each municipality has different incentivization program. Like some municipality provide the nutritional food, some municipality provide nutritional food, including free ambulance services to the community to health facility, one health facility to referral health facility, and the few municipality give the some additional money as well. It depends on their resource of their one municipality.
Perfect, thank you. And we have a question. Sneha, did you want to ask a question?
Hi, yes. Hi, Kitty. Yeah, hi. Yeah, thank you all for the the insightful conversation. I think it's been really interesting learning about how One Heart measures impact and what's the whole the program. And my question was, like, because One Heart works in so many different districts, like in terms of impact, what do you think are some of the factors that really helps drive impact in some areas, districts, some municipalities versus others? What are certain factors in a given municipality where the work of One Heart would really do like drastically better versus other municipalities? That was my question. And also one other question was, what support do you think can be provided from Kathmandu, from like networks and doctors in Kathmandu, in order to support the work that One Heart, or supplement the work that One Heart is doing in the districts, or if there is any? Like, I'm sure a lot is done already, but because I actually run a digital parenting platform called Yoma, and Yama means dear mother in Newari, and we work with a lot of different doctors, pediatricians, gynecologists, lactation consultants, which there are very few in Nepal, but it's a few. And if there's any way that that we help with regard to information, or I don't know, or any way using these platforms in those areas. Yeah, was my other question. Thank you. Sorry.
So okay, Katie, can I?
Yes, go for it.
Okay, so the first question that Sneha asked, so what makes the difference between the two municipalities with the impact, like, to answer that question, I have already mentioned before, there are certain factors where that has the effect in doing good work by a few municipalities against the others. So the foremost thing is, like, when we compare, like, for example, we phased out from Hading district 2 years ago in 2020. So I mean in 2019. While we went there for a meeting, for a formal closure meeting, we had invited all the elected members and the health unit chief of each palika, or the local government. the municipality. So there we found that lots of activities that One Heart was doing were, taken by the Palika itself. So the one reason why it was that district overall was doing great. So we went through that, like how was that possible. So the foremost thing is the health unit chief was very capable. They had the background with the public health, and they were being able to plan, kind of with the activities, especially when we talk about the maternal and newborn health. So they had prioritized health with special focus on maternal and newborn health. So the one thing is like very capable health unit is one of the foremost thing that's very important for each palika to work perfectly, because planning is, they say it's half work done, right? So they had prioritized health in a good way. That is the first thing. And the others is like, uh, if they have good resource in terms of budget, and also the good person in the health unit, so they can plan with activities that can bring a great achievement or the impact, you can say. And also the staffing that gives lots of things that bring strong, the strong team in the health unit brings great activities, and that was executed well with good team mobilization. And so all of those were the reasons that I think had taken the activities that we were doing in a good way. And in the other districts that we have been phasing out, some of the palikas are doing great, some are not. So the factor is, they have again, the foremost thing is a good health unit, capable health unit is very important to do all of these things. So that's the foremost thing I would say. So if there's anything to add on, Bhagawati or Liladhar sir can add.
And the other thing is like when we go in one district, we don't do in one municipality. Our program will be at district wise and based on the need. Of course, our focus is in only maternal and newborn health, but to develop the capacity of the health section officials of the municipality, we cover all the health areas. And in addition, the next questions, you mentioned that how do you raise with the doctors and in heart level. So basically in our program district, in any means, we raise to the all the health workers at our program district. From any means of different from different meanings, especially after COVID. After COVID, first wave of the COVID, we started the maternal and neonatal health MNH health plan. We call the MNH health plan. At this program, normally our remote birthing center nursing staff call to the district hospital level doctors, specialists, expert, if they need any support in their birthing centers. That's how the remote birthing centers staffs and our doctors who work in district hospital are connected. And the other things is like district hospital is one of our major intervention site. So we do the different kind of things with them to improve the maternal and newborn health services in their own health facilities as well.
So can I know more about, like, Sneha, can you tell more about what was the organization that you were talking about? So who are the human resources? What does it do? So if we get more details on that, then we can answer you more. Sneha?
Right.
Hi, yeah. So the organization is called YOMA, YOMA. It's yomanepal.com. So it started with just to kind of talk about build a community of parents, of mothers in particular, to kind of talk about the real and raw side of motherhood, And it started in Kathmandu. I mean, it's currently like mainly like people in Kathmandu who contribute. So it was surprising. A lot of people started contributing their stories on infertility, miscarriages, postpartum depression, breastfeeding issues. And these are all people in like Kathmandu. And also like we did a post on psychologists for mothers to reach out to, and it kind of went viral. So that's why we have 5,000 plus followers on Instagram now. It was a really like, it was a post, I guess, because people even in in Kathmandu, they know they need help, but there's stigma attached to it. So what we did was we made a post where we put the name of the psychologist, the timings, the price range, everything. So they could just look at it, and like those psychologists got like sold out, as in like booked out. So we did part 2 and a part 3 of that. So it's like when you have a broken leg, you need to go to the hospital, but like you can't get to the hospital. So now so many people here need that support, but they're not being able to reach out to the right resources. And this is 2 years back we started it as an online platform. So we started doing Insta live sessions with different doctors, nutritionists, gynecologists, pediatricians. We've done a lot of those.
Okay,
So
so that
I can
means,
share
yeah,
information,
your
yeah.
target audience would be more of the urban residing women, right? Or has it reached to the villages also?
Yeah,
The
so the goal was we started off like in the urban areas, but definitely the goal is to reach remote areas also. Like we've partnered in some ways, not like actively, but like with Sochai, we did a Q&A session with Dr. Neera Singh Shrestha from Medicity. She's the head of the gynae department at Medicity, and it was very useful, like very informative things in the Q&A. So then we had that transcribed to Nepali, and now Sochai is using it with their women's group discussions. So some of these things have been translated and used in pamphlets, in brochures. Like some of the interviews we've done with the doctors have been used in that way. It's been translated to Nepali, and so that's some of the way, because I have had a background in the development sector. Like I'm working in economic development in M&E for quite some time with Louis Berger and IMC, and then and I've been to these areas. I've been to like Taplejung, Doti, Daliltura, across. I traveled a lot for my work, and only once I had my kids. Now they're 5. Is when I started left the development job and did this. So I have like a very big interest in like expanding to the wider communities across Nepal.
Yeah, that's great, because One Heart is also starting up, like, because One Heart works in the very remote areas, and we have, as Bhagawati mentioned, we have started the MNH helpline, connecting the women or the health service providers with the doctors in the higher facilities. And also we are now planning to reach to the women. There has been a challenges, to reach to those women. There's a network problem, and they do not have the cell phone or kind of thing. So we are exploring about that, and we are planning with that also. So I think if we can talk more on like in future also, that would be a great help, because this mental health or the postpartum depression and all of those things are very important now. So it would be a great collab. So we may talk more on this in future also.
Definitely. And we're also collaborating with, you've maybe heard of Transcultural Psychosocial Organization, TPO.
Right. Yeah.
They are doing a research with King's College in London on maternal health, on postpartum depression in particular.
Okay.
And so we are also, I'm a trained art therapist also, so I've done it in the past, and we're kind of working together through Yaman. Maybe we can discuss it also, because they're doing a long-term study on whether or not the effectiveness of this of their particular methods. So if that works, and depending on the findings, I think it's gonna, like, it's been a while that they started it, so then One Heart could possibly then take up that model if the findings are, if the findings make sense.
Yeah, sure. Yeah, I would love to know that, like if you share that after the report is out.
The postpartum depression is one of our next priority areas where we're starting to talk about it.
Yeah, definitely very important.
making so many connections. This is awesome. I'll connect you guys afterwards via email so that you guys have your emails and you can discuss later. Great.
Yeah, thanks.
Okay, awesome. So are there any other questions before we close out for today from anyone else? Okay, yeah, Zayuan, go ahead.
So sorry, I was late, but when I was here, I was thinking that you are talking about nutritious food, because my background is in nutrition, especially how traditional medicine and traditional food perceptions affect postpartum diet and postpartum dietary restrictions. So I'm wondering whether you have discussed this field, and I'm wondering, are there any ongoing projects related to this field? Thanks.
So what was that, Katie? Can you please elaborate on the question, please?
Yeah, so Zayuan, he is a PhD candidate and he studies nutrition specifically. And so he is wondering, he's been asking me this and I'm like, I don't have the answers for you. So he's wondering about nutrition and how that plays a role in our programs and if maybe that's something we would focus on in the future.
Yeah, and especially how like traditional health perceptions, food restrictions, traditional medicines, indigenous perceptions, like how those factors affect people's nutrition and dietary intake. Yeah.
Bhagawati, will you answer that?
Yeah. Hi, Jill. Of course, yeah, you are right. I don't have the exact answer about it because yeah, since 3 years back, there was so many our traditional perception and culture that we had so many restricted on the food nutrition, different kind of food to the pregnant mother and to the postnatal mother as well. Now there's these traditional things is let be going down in our perception only, but we don't have the exact number how many percentage are adopting the modernization nutritional therapy. But of course, definitely the traditional cultures regarding the and the food reaction to the pregnant and postnatal mother is going down. Moreover, the other thing is like is a national, international problem. Like people are more like people's habit are increasing in the junk food rather than their the nutritious diet because of different things. You know that is a worldwide problem. Especially in few communities, like in Himal, Hilly, and Tarai region, different ethnic group and different communities has still different kind of restriction on diet still.
Yeah, okay, thank you.
And of course, the focus regarding our focus on the nutrition program. Actually, till today, we are focusing on the system is strengthening first. First, build the system for readiness, like readiness of in terms of the service provider, well-trained service provider, well-equipped home birthing center, and the well-managed birthing center with medicine and all, and then of course this certain increasing the number of the service seeker, and the nutrition is the one of the component of our community level education, and as well as one component of the health worker training also. So nutrition always comes in every topic and every discussion and meeting, but not we are doing the only the nutrition program. We are integrating it in our program.
Okay, thanks for sharing.
Perfect. Okay. Any other questions for Liladhar, Babita, or Bhagawati? Okay. Wonderful. Thank you guys all for being here. And thank you to Babita and Leela and Bhagawati for talking with us today. This has been, I think I told everybody, this has been even helpful for me to learn more about exactly what we're doing in Nepal, and learning about how we actually measure impact and how we're going to do that going forward. So thank you, everyone. And we'll end here. If you have any other questions, feel free to send them over to me and I can forward them over to any one of the our guests here today, and maybe they can answer it via email if you need to. Okay. Bye, everybody.
Yeah.
Bye.
Bye.
Thank you.
Bye.